welcome you all to this second LTSI Masterclass. So today's topic is acute liver failure, and acute liver failure, as we all know, is one of the most challenging situation in hepatology and liver transplant, and if not treated well, can lead to very high mortality. And today we have great experts who have great experience in managing these kind of patients, and we are going to learn the latest insights in acute liver failure management, the controversies and the prognostic markers and role of liver transplants and novel therapies. And we're going to listen to their real life cases. And I'm now going to invite Dr. Saigal, who is now the president of LTSI, to say a few words before we start the topic.
Thank you, Abhijit. It's an absolute delight for me to welcome you all on behalf of LTSI. I can see that we have more than 100 participants today. There's a second in the line on the masterclass, which has been designed. Abhijit has done a fantastic job. So this, I'm sure, will be a continuity where we will be dealing with a topic which is focused, and a team and a very expert, part of our, our LTSI groups will be taking up. So I think, going to be learning a lot in this, and I think especially the fellows and trainees, I think for them it's going to be very useful. So with these words, I again welcome everybody to this very exciting session, and over to Abhijit to invite Professor Gupta for his first overview.
Thank you, Dr. Saigal. And before I invite Dr. Gupta, I would like to request everyone, if you have any questions, please type it in the chat box. And once the topic is done, we'll address all these questions one by one. Now, moving on, good evening, Dr. Gupta. It's actually a great privilege and honor for me to invite you to start today's masterclass. And with your kind of experience you have for acute liver failure, managing these patients, I'm sure we are all going to learn a lot. So over to you, sir.
Thank you very much. And I think the audio is not very good. Can you hear me clearly?
Absolutely, sir.
Okay, so my job is very simple. We had sort of great debate in the run-up to this meeting in trying to see what's the best way to go about it. So I've involved a lot of people so that we can hear everyone's views. And also what I've done, what I'm going to do is very simple. I'm just going to tell you, give you an overview of acute liver failure as we've seen it in India. Next slide, please. I think Rajshekhar is Rajshekhar, are you there? Can you have the next slide? So the plan for the master class is this short overview by me. Then there'll be prognostic markers by Dr. Shekhar, who's a hepatologist, ICU care by our HOD, Dr. Arvind, pediatric acute liver failure by Vipul, and when not to transplant by Dr. Day, anesthesia for acute ALF transplant, a little bit on surgical technique. Then we have case presentations. We're going to be very interactive. And in the end, hopefully, Saigal will give a summary of what was discussed the whole day, whole evening. Now, for me to give this overview is, first of all, as we know, acute liver failure is potentially reversible, and often the killer is cerebral edema. Intracranial hypertension has been monitored by insertion of bolt in Birmingham, where I trained, but this is not found favor in India. More popular is non-invasive monitoring, such as with optic nerve sheath diameter, which is more popular. Next slide, please. So now, ALF management in India, even now, is still limited to non-transplant centers. Even though we've been doing transplants for over 25 years now, and most non-transplant centers tend to treat with PLEX and CRTC because they think that transplant is not an option. Whereas those who come to a transplant center may end up or will have an early transplant. So in this presentation today, we thought we should come to a sort of a understanding where PLEX is needed, where transplant should be expedited, And one of the problems that, of course, has been in India that referral system is not robust, and patients often choose where they would like to go. Next slide, please. So the outcome in ALF is determined by four things. One is the acute phase where you have inflammatory response syndrome. Once that settles down, then cerebral edema. And in the end, some patients who are actually recovering from liver failure end up with secondary sepsis. And of course, at the background of all this, what is the ability of the liver to regenerate? For example, if you have somebody with sort of fatty liver disease and he also gets acute liver failure, then obviously they're more likely to succumb, which we had recently in one of our cases. So the prognostic factors are based on age, etiology, jaundice, and encephalopathy interval, ICU care. Next slide. And PLEX and CRRT have been used in many transplant centers. Now, one of the problems that we've faced often is that with PLEX, you change the INR values, which is not there, which means that you're not able to do a dynamic assessment. And CRRT has been advocated for ammonia clearance, even without renal failure, but it's questionable whether CRRT can be better than native kidneys. At least I think that, if your kidneys are working, then perhaps CRRT. But these are the issues we could discuss. And also, one must remember that once you introduce CRRT, just to reduce ammonia, you will have to use anticoagulation to prevent line blockage. This becomes particularly important in young children. And if you use citrate, you can end up having a sort of failure of liver to convert this to bicarbonate. Next slide. And in pediatric acute liver failure, which Dr. Vipul is going to cover in detail, I think one of the points we stressed is that encephalopathy can be subtle and often be missed, and hepatitis A and E continue to be a big menace in our country. Next slide. So in the end, we have two case presentations, which will cover some of the important points from day-to-day management. And I think we will ask whoever's here, and or anybody could be, these questions could be directed to all the sort of people who have been listening. So first is a child with very advanced cerebral edema, and second is a case where transplant could have been justified but showed spontaneous recovery. And then thank you, Abhidi, for allowing us to be part of this masterclass. Over to you.
Thank you, sir. So moving on to the next, Dr. Sahgal, can you actually take it to the next one?
Yeah. So what we will do is we have a next talk, which is actually very important. It is on prognostic markers in acute liver failure, which Dr. Gupta just mentioned is probably very, very important thing for us. And we have Dr. Shekhar. I would request the speakers to speak about 8 to 9 minutes, not more than that, so that we have adequate time for the cases in the later part. So Dr. Shekhar, would you kindly start your presentation on prognostic markers in acute liver failure? Dr. Shekhar is our senior hepatologist in our team and with a huge experience in dealing with such patients.
Good evening, everyone. Can you see my slides?
Yeah, you're audible as well.
Good evening, everyone, and thank you for Dr. Subhas Gupta and Dr. Sandeep Sehgal to giving me this opportunity to present my presentation today here in LTSI Masterclass. I'm going to discuss about prognostic markers in acute liver failure. As we know that many patients with ALF, they survive without liver transplant, but at the same time, liver transplant is life-saving in rest of the patient who are not recovered spontaneously. And this dilemma remains how to manage these patients medically and whom to transplant, and what is the right time for listing for liver transplantation. ALF is defined by three criteria, as we all know, that rapid development of hepatocellular dysfunction defined by jaundice and coagulopathy, encephalopathy, and absence of prior history of any liver disease. And further, ALF can be classified depending upon the duration between encephalopathy and jaundice and onset of the encephalopathy. Hyperacute when it is less than 7 days, acute when it is 1 week to 4 weeks, and longer period is called as subacute liver failure. And this classification is important in prognostic view because the hyperacute are most likely to survive without the liver transplant, and subacute are they are most likely they're gonna need the liver transplant. And in ALF, the prognosis is depend upon the degree of the cyst, inflammation, presence of the sepsis, cerebral edema, one of the most important factor defining the prognosis and mortality, and ability to regenerate, spontaneous regeneration in native liver. So LDLT versus DDLT, there is no difference in outcomes. In LDLT, timing can be more accurate as compared to DDLT. We get better graft quality in LDLT, while the bleeding complication is little bit higher in LDLT patients. In liver transplantation, the most important the clinical decision making is when to do the liver transplant, and we always avoid to do LLT early, to avoid the LT in the patient in which the spontaneous recovery is possible, while avoiding the transplant too late because this can lead to a permanent neurological damage, sepsis, multi-organ dysfunction, and transplant can be futile. So the one of few important prognostic factors that decide whether liver patient gonna recover spontaneously without LT. One of the most important factor is degree of hepatic encephalopathy. Those who have the grade 1, grade 2 HE, they have most likely the chances to recover spontaneously, while the advanced HE patient they have less chances of spontaneous recovery. Another important factor is jaundice to encephalopathy interval. So hyperacute kind, they most of them will recover without the need for liver transplant, and longer is the duration, the lesser is the chances of spontaneous recovery. While the younger patient and older than 40 patient, they have less chance of spontaneous recovery. Etiology also important, indeterminate cause have poor recovery rates. And the serial trend in clinical status and the laboratory value like the decreasing ammonia, improving INRs, they define, and the chance that these improving serial trend. Prognostic factor, we have many prognostic factors that have been used into the past and being used currently, like the King's College criteria. These are one of the most commonly used criteria. MELD have not been explored into the larger prospective study. Clichy criteria, but is not commonly available into the centers in India because of factor 5 lab assessment. And bile criteria not been validated prospectively in the studies. Other criteria are alpha models, but we can assess only after the 48 hours. Then ALF-HG scores, and this we need a measurement of the M30 that may not be available into the all hospital centers. Then ALF organ failure, but still awaiting validation into the non-PCM kind of ALF. Clinical prognostic indicator, another factor, but the series in which the study they presented, they have no patient actually underwent the liver transplant. So the most commonly used criteria is the King's criteria that was developed in 1989 involving about 588 patients. And the data they use is at the time that the transplant was not that much common. And it is one of the most commonly utilized prognostic score. But the criteria has poor sensitivity and poor negative predictive value. And many of the patients who do not criteria still died. So this is as we all know that the criteria, the factors we use in PCM, ALF and non-PCM kind of the ALF. And the studies systemic reviews and other studies have shown that the criteria have poor sensitivity or 58%, but higher specificity or 95%. And one problem is that the low negative predictive value means the criteria is better able to predict the patient who have poor prognosis as compared to those who have good prognosis. So other studies have said that the good specificity or poor sensitivity of the test. And the criteria have shown a better prediction into the past study as compared to the newer, because because of the improving critical care of the ALF patients, the performance of the test is not that much good as used to be into the past. So the fulfillment of this cases criteria is useful in predicting the death, but lack of the criteria doesn't predict the survival. But still, most of the center, this is the criteria that we commonly use. Other criteria, the alpha criteria, in which we use the hepatic encephalopathy, INR, ammonia level, and the serum bilirubin level. But the criteria need at least we can use this criteria only 48 hours after the patient admission. We may lose the important time window. this CPI, another the criteria we use, but in this series, the no patient actually underwent the liver transplantation. So and also it's not that commonly used criteria. And another in this recently published study in 2018, they have actually studied the liver volume by using the CT volumetry, and they found that when the liver volume is less than 1000 cc, these are the patients who are more likely to have regenerative failure and poor prognosis and likely to need a liver transplantation. So, in conclusion, the no prognostic model is perfect. There's a wide variability in these models and with limited efficacy. ALF is a very dynamic disease, and prognostic markers are to add in decision making, and they cannot be the sole basis for the decision. And physician evaluation and risk assessment is very crucial for making a reliable decision making and treatment options. And clinical deteriorations and sign and symptoms of the cerebral edema are the definite indication of liver transplant. Thank you. Thank you very much.
Thank you, Shekhar. Before we go on to the next talk, can I request Dr. Gupta and Dr. Saigal, in the clinical practice, I mean, we all know there are multiple criteria. In the clinical practice, what is your go-to criteria for deciding which patient you'll continue with medical management and which patient you'll definitely go for transplant?
See, two things. One is that we will be once we have the short presentations, then in the case discussion we will try to generate all these questions so that we will have like time enough for that. As you speak, I mean, in clinical practice, an excellent question. I think this is the most difficult question to answer when we manage ALF, and I think the dynamicity of the problem is most important. So we somehow tend to still, like have a mental fixation towards the King's College criteria, knowing very well that our population is different, our etiology is different, and this may not be very much suitable to our own population. But if you see the publications which have been there from our Indian centers, it is somehow being practiced. So what we see the clinically, I think what I personally feel is that when you see a patient, you see what is the actual dynamicity of this patient, see what the course in the next 6 to 12 hours, and delta changes are most important to me in this situation. And the tendency to reject is much less. We try to be more optimistic. But yes, if you ask me that, do you have a fixed number on which we follow? I would say no, fixed numbers are very difficult. You can have like, you can mentally think that this patient is not going to make it or is going to be, good. But what we do is in practice, because patients come to us, no, mostly they are late referrals, they come from other centers. The first patients have been dealt in outside centers. So when they come, they're already having some other, problems at the same time. So we do actually tell the patients if they're genuine ALF in grade 3, grade 4 on ventilator, that you get yourself, prepared for a donor, get evaluation done. But yes, same time we start intensively the medical treatment, whatever we can do to salvage these patients without transplant. So that's the way I look into it. I don't look at the numbers very strongly. It's just the dynamicity of the entire thing which determines our decision.
So, just to add on to what Dr. Sehgal has said, I think what we have to be on guard all the time is cerebral edema. Because once that happens, so unfortunately, we so far have not had an agreement on what is the best way to look at cerebral edema. I mean, in Birmingham, where it spent a couple of years, intracranial bolt was the norm. But I think more recently, we have tended to use optic nerve sheath diameter as a marker for cerebral edema. Or if you have had sort of changes which are suggestive, so for example, hypertension, bradycardia, seizures, then these are signs of cerebral edema, and these are patients who perhaps should be expedited for transplantation early.
Okay.
So now,
So just one more question that came up in the chat box. Do you ever use Alfred criteria?
so do you want me to answer that, or Dr.
Yeah.
Sehgal?
Yeah. See, it's actually a very good question. Actually, if you ask me, in my mental framework, I would really consider Alfred criteria whenever there's an opportunity. Okay. And in fact, subconsciously, we all are following these criteria. Believe me, when the patients come, we look at the previous, outside INR, outside reports, outside bilirubin, when they come to you. So it's like that. It's there, it's there. But when you have to be very purist, you cannot sometimes, get the right values which are there. So I would not just wait in my ICU for 48 hours and see what the number one value. I would like to have a value which is existing from the previous referral center, and that I would consider. But I would not like be a purist and keep on waiting and waiting, waiting and see what happens in 48 hours. That is not really advisable. If there's last cerebral edema, you just have no opportunity to do that.
Another quick question. Does time from onset of hepatic encephalopathy to referral to your side a prognostic marker?
Yeah, of course, I mean, we all know that those which are, like hyperacute liver failure, I mean, if you're willing that hyperacute and acute feeling, meaning if you're willing that, right?
Yeah,
No,
I
no,
mean,
no, Dr. Saigal,
not really.
I just put that question because a late referral. If the patient comes, is referred to you late, and then do you try medical management or directly go for a transplant?
Uh, See, in fact, if you ask me, majority of the referrals which are coming to us are actually late. I mean, if you see now, all of us when we deal, patients that they come, they have been in outside ICU for 1 or 2, 3 days, and they come to you. So directly, still, I would not do. I would still wait, and I would honestly, give them a chance. And I know that those who are, hepatitis A and all.
If you were to think of LDLT, then it cannot be done immediately in any case.
Yeah.
I mean, there's no way you could do an LDLT as soon as the patient comes, can you?
No, you should not also.
Cannot do also. I mean, even if, so they need, I mean, minimum, there is always between 24 to 48 hours before you can come to a decision because that transplant should be, is needed. So in real terms, there's very rarely there's an but we've had situations, of course, where they've been in another center with another group and they've been in discussion with us that they've been managing the person not doing well and they've worked up the donor and they would want to refer you for transplantation. That would be a different situation. But if they already, if they come here, there will be a period of sort of interval where you will be able to see the dynamicity. You will, of course, if the lactate is high, you would like to sort of give them fluids, try and improve it. If there's some cerebral edema, then you do a little bit medical. The problem sometimes happens is that, which we face in day-to-day practice, is if they've had plasmapheresis, then it's almost impossible to follow the trend. So most centers end up justifying this by saying that we have no option of transplantation, therefore we persist with PLEX and CRRT. But in a center like ours, which we do both sort of medical management as well as transplant management. I think the dynamicity is the most important factor that has emerged. And of course, if the cerebral edema tends to get worse, then you have to expedite.
Absolutely.
Absolutely agree with that. And another quick question is CT volumetry practically possible? I mean, would you do a CT volumetry to make a decision on transplant?
No, we should not. I mean, the liver volumetry, right?
Yeah, that was done. I think there's CT volumetry, and there's another one by, I think, somebody whom I know very well. He published that if you have a biopsy, 70% necrosis, then the chances of spontaneous recovery are close to zero. But of course, in situations where you are in doubt, not clear, you could use these ancillary factors to help you in decision making.
I mean, the CT, only thing which I would like to do CT is before shifting to OT, I want to see that there is no intracranial pathology, there's no bleed and all, right? And cerebral edema, how bad it is. But to assess for prognostication, a liver volumetry, I would not be very, perfect. So could we move to the
I'll interrupt the questions here and we'll move on to the next talk. And maybe then after the next talk, we'll take up the next few questions that are coming up in the chat box.
So this
So
is
over
by,
to Dr. Arvind.
Yeah, Arvind, yeah, please.
I think Dr. Arvind's mic is mute. Dr. Arvind, mic is mute.
Yeah.
Arvind, could you unmute?
Unmute. Yeah. Can you listen? Am I audible?
Yes.
Yeah. So we move on to the next slide. So the hallmark of acute liver failure is coagulopathy and altermentation in a patient without pre-existing liver disease, duration of illness less than 26 weeks. So the liver injury or due to this pro-inflammatory mediators, they lead to multi-organ system failure causing cerebral edema, circulatory collapse, respiratory failure, renal and sepsis, and that is what you are going to manage. Next slide. So those patients which need to be admitted in the ICU on a daily basis should what has been checked has been in this slide, which I'll elaborate more further. Next slide. So the most important is the general supportive measures. Is the initial care. You should assess and improve the airway, breathing, and circulation. And if there is a early hepatic encephalopathy, especially grade 3 and 4, we need an early intubation, and we must be extremely while intubating, well, because there will be rise in the intracranial pressure. The fluid management is very important, and to ensure a very decent urine output production. So all these management practices, which I'm going to talk, is a developing consensus with the various literature with a very weak empiric data. Next slide. In the fluid and the hemodynamics, the ALF patients are typically hypovolemic, and because of the hyperdynamic state with peripheral vasodilatation, with systemic inflammatory response syndrome, and a cytokine storm resulting in end organ perfusion. So we have to have a fluid resuscitation and also inotrope. So norepinephrine is the preferred choice. And if there is an inadequate response, that needs the prompt addition of vasopressin. And we target MAP, which you do in ICU, is to maintain over 65 millimeter mercury. And the assessment of the end organ perfusion is also important to help guide the mean arterial pressure. Next slide. So the overall broad spectrum antibiotics with fungal prophylaxis, and the role of hydrocortisone has been controversial, but sometimes is given as a single dose. So we have to monitor blood glucose as hypoglycemia, very common. N-acetylcysteine routinely started in non-paracetamol acute liver failure, and early parenteral or enteral nutrition would help. Next slide. The assessing of the neurological status is very important. So what we follow is pipilometer for assessing pupil size every 2 hours, with nursing in the head, end elevation with minimal stimulation, and tracheal suctioning with chest physio when the patient is completely sedated with propofol and fentanyl. So the management of the cerebral edema is the key feature in ALF. So recent trends have even to rely on RTT with even normal renal function for clearance of ammonia and control of edema. And a high serum sodium also left around between 138 to 145. And the measurement of ICP by Bolt is also controversial. Next slide. Cerebral edema management consumes mannitol bolus with a hypertonic saline and resuscitation of propofol and fentanyl, and an expedient for liver transplant. Next slide. The monitoring of edema, although it was previous literature, there was done, but there is no documented proof for the outcome or neurological function in intracranial monitored patient. But there are certain non-invasive ICP monitoring, of which optic nerve sheath diameter, which we use in our ICU days. And there are other things like transcranial Doppler, which you have used sometimes. So in refractory cerebral edema, ammonia scavengers are used, and we maintain therapeutic hypothermia of 32 to 34 degrees centigrade. Next slide. Next slide. Every effort should be made to prevent renal failure by improving the hemodynamics, which is very important, avoiding the nephrotoxic drugs, and early treatment of infection. And RRT for hyperammonia alone, which is very debatable if renal function is intact. For the anticoagulation is also necessary, sometimes induced with heparin also. Next slide. Plasma exchange, which we used to do, but in our center is not be of much help, because INR is affected once PLEX is initiated. The trend in INR is often the deciding factor for the need of the transplant. The best reserve in situation, liver transplant is not going to happen. Next slide. There are hemostatic abnormalities in patients with bleeding diathesis, markedly elevated INR and thrombocytopenia. There are compensatory mechanisms for hemostatic deficiencies, which are identified in each phase of coagulation. So the low procoagulant proteins are rebalanced, what is called rebalanced hemostasis, which lead to an increased levels of factor VIII. So global hemostasis should be assessed by thromboelastography and rotational thromboelastometry. Next slide. So some recommendation for blood component transfusion before you do an invasive procedure, like when you have an INR, the threshold is unknown, platelet is less than 60,000, fibrinogen less than 100, and hemoglobin less than 7 gram per deciliter. Next slide. Infection, ALF is an immunocompromised state due to the dysfunction of neutrophil monocyte corpuscles and a complement system. Fungal infections are also common in 30% patients. Candida albicans is common, and selective gut contamination and non-observable antibiotics has not been shown to improve survival. Next slide. So the transplant remains an option, and it has been shown right lobe liver transplant shown to improve survival of adult patients in ALF. Next slide. So what is the future? The future liver-assisted devices and acute liver failure with renal replacement therapy, plasma exchange, fractionated plasma separation absorption, albumin dialysis principles, MARS, SPAD, and bio artificial extracorporeal life support hepatoassist. Next slide. This was a summary. Next slide. Next slide. So these are my references, and thank you very much for the patience. Hearing.
Thanks, Dr. Arvind. There are a couple of questions that are in the chat box. When do you decide to initiate CRRT?
CRRT is we generally, even if the renals are normal urea creatinine, we still want to start CRRT early.
Can I answer that question
Sure, sir.
a little bit? Because it's a very, very pet topic of mine. Now, CRRT, there's renal dysfunction, there's no dispute. There's renal dysfunction, low anuria, low urine, urea creatinine rising, there's no dispute. Now, the debate really centers on whether doing CRRT in presence of normal function will bring down the ammonia or not. And we know that to do that, and I think Bipul has done this, spent a lot of time in Japan, and that you really need to do high volume to just bring the ammonia down. So we can hear from him on this, but as has been a practice, we've not, if the renal functions have been normal, the two problems with doing CRRT in a transplant center. One is that you cannot do CRRT without some form of anticoagulation. It's just too expensive. The lines will clot off, and the second is that I mean, there's some prostaglandin that we used to use in Birmingham and elsewhere, and Dr. Vipul has some slides on that in Japan. But the other thing is that you use citrate, then you have to monitor citrate and ensure that no toxicity from that. There have been some terrible crises from use of citrate as anticoagulation. So in brief, CRRT we would do only when there is renal dysfunction, not just to bring the ammonia down. But we can discuss this later with some of the people from the rest of the country who are actively engaged in treating acute liver failure.
Sure. I mean, I'm sure there are various people doing different things. What we follow is, as soon as we have a ALF patient, while we are preparing or managing, we put them on CRRT, but I'm sure everyone has a different protocol. Another quick question, ventilatory maneuvers for cerebral edema. Dr. Arvind, would you want to talk about something which are found useful or not useful in ALF?
The most, whenever there is cerebral edema, you have to sedate the patient completely. And normally we do with propofol and fentanyl. to keep it sedated with a bispectral. We keep the bispectral index in the range of between 30 to 35. That is what.
And any particular ventilator settings you would want, or any particular kind of ventilation you would want for these patients?
Normally, we ventilate with SS controlled PRVC in our ICU, and even volume control doesn't have any issue with a low tidal volume strategy.
Okay. And a quick word on antifungal agent you prefer for ALF or prophylaxis.
So if I can answer that.
Yes.
So the antifungals, if you see, even if you're not doing a transplant, I mean, the studies have shown both from, abroad as well for AIMS, Professor Chara published this, that you do need to cover them with antifungals. These are very sick patients, especially now the patients who are in our ICU, who are on ventilator and are going for a transplant. I would strongly like them to be an antifungal cover. Best is, in fact, I mean, traditionally, one were using, the one of the fluconazoles and all, but in ALF patients, I know it's pretty much, okay to you go for amphotericin actually, or sometimes people are using micafungin as well, or one of the one of the fungins actually. But if somebody is very sick who's going on a transplant, then I would like to give them a proper antifungal cover as they get shifted to the OT, because they're very sick, they're on ventilator, and they need a cover. I mean, going through is that whatever is available in your practice, but you should cover them adequately.
Echinocandins or amphotericin?
I have been, traditional. I've been following with Jules Vanden, in Kings, and I know that I was trained with amphotericin. So my personal touch is with liposol and amphotericin if it's not a problem with affordability.
Okay. Do you use HA230, 330 filter for removal of bilirubin, ammonia, cytokines, or that is not a protocol in your center?
No, it's not a protocol in our center. We have used bilirubin filters in other situations, in non-ALF. I've seen that. I've used it in some very, very, high-end situation. Believe me, it does not lead to a final improved outcome. The bilirubin comes down up to 10 to 15 milligram percent per day. The bilirubin value comes down. For 40, it will come to 25. And you don't do it for about 24 hours. Next day, third day, if you do the bilirubin, it again shoots back to 40. So it does not give a sustained improvement. That's been my experience. But if somebody has used it in a different manner, the most welcome to comment on this.
So Dr. Arvind, is propofol or fentanyl doses guided solely by BIS values, since in ALF, BIS values are often in the lower range?
Obviously, they are guided by the BIS values. We try to keep the BIS below 40. And even if in between we require to also give an intermittent bolus, otherwise we prefer to give an infusion of propofol and fentanyl.
Great. So if anyone else is practicing something different, they can type their protocol in the chat box. So we'll move on to the next talk.
Right. So Vipul is going to present on pediatric ALF. He always says that children are not miniature adults, right?
True, sir.
So please, emphasize on what you want to convey to me and what you think about pediatric acute liver failure. Thank you.
Good evening, all the experts. I'm Dr. Vipul, pediatric hepatologist from XCLBS, and I'll be talking about pediatric acute liver failure and how is it different from adult population. Next. So before I go ahead, just a small point to make. Children are not miniature adults. They have to be dealt differently. So my talk includes initial management, the wrath of viral hepatitis on India, standard medical treatment versus liver assist devices, whether they are useful or not, the liver transplant listing criteria, are they really useful, and when to proceed for the transplant versus shall we wait for the native liver to recover? This question needs to be answered. And our max CLBS pediatric ALF experience. Next. Yeah, so everybody knows the definitions of ALF, but pediatric is little different. The main difference is hepatic encephalopathy. Unlike adults, next. Next, unlike adults, early HE in children with PALF is difficult to assess. They are always irritable, crying because of various factors. So we just can't say they are in hepatic encephalopathy. So it becomes quite difficult for them to assess ALF. So by definition, if INR is more than 2, even without HE, this is PALF. Next. So as we know, there's a wrath of viral hepatitis on India. Mostly this hepatitis A and E are doing a very bad job. And almost 50% of various cohorts are because of this hepatitis A and E. Next. Like in this study, almost 50% are viral. Rest are metabolic, as we are dealing with pediatric, and autoimmune and drug induced. Next. The similar data came out from our study from 17 to 24, where we included 70 patients with 42 adult and pediatric 28. Next, and HAV almost 55.7%. Next, the pie chart shows the same, with majority of patients are hepatitis A, pediatric plus adult, followed by indeterminate and other etiologies. Next. So before we start talking about past management, there are the simple things which we always should keep in our mind before starting. I'm not going into details, just giving you just about it. Like everybody asks, should we give FFP? The answer is big no. Just for the sake of INR, FFP should never be given until there is bleeding or invasive procedure. We have to be guided by TAG if possible. And there is no recommendation for high bowel wash, hypothermia, or extended hyperventilation. I read a question in the comment box. That's the answer of that. And there is no indication to keep the children without enteral feeding. As soon as possible, even with advanced HE, when the child is on ventilator, we should always start nasogastric feeding with 0.8 to 1 gram per kg day proteins, because sometimes zero proteins leads to myolysis, which further increase ammonia. So we have to balance everything. And as we know, NAC is controversial but universal in India, and so we do. Fluids, electrolytes, and infection, everybody know how to deal with that. And as per the etiology, we have to deal with the patient. Like autoimmune, obviously need steroids to try before going for the transplant. Next. And coming on the monitoring of raised ICP, which is very important. Now, as we know, the data is in favor of ONST. So we also do ONST very frequently and repeatedly. It's easy, practical, and everybody in our ICU know how to do it. And from the literature, taking from the literature, ONST more than 4.6 is significant. Other useful modalities, transcranial Doppler, I would say it is really good, but for small kids, when they're in early HE or they are irritable, it's difficult to do practically. So if the patient is in advanced HE and intubated, then only we can use it. They are automated TCT, but they are very expensive. Others are not much useful, like jugular venous oxygen saturation, NIRS, they are not much useful, not much pediatric data. Continuous EEG can be used. It needs expertise to interpret, subjective interpretation. It can guide the progression of HE, and it also helps in detecting early seizures. Next. So what we do in CLBS, we go by clinical parameters. We go by Cushing triad. We go by size of pupil reaction. We go by ONST and TCT. And before starting the surgery, we do brain imaging. We have a portable CT and we do brain imaging before starting the surgery in OT. Next. So coming on the prognostic scoring, there are a lot of LT listing criteria specific for children and all. Next. But none of them is specific enough to describe when to actually proceed with LT. Next. So what are the practical points? When should we proceed for LT when we are not relying on these LT markers? For example, KCHC. Everybody talks about KCHC, but we all know that it leads to overutilization of liver transplant. And kids should always give a chance to survive with native liver if possible. So what we do, if a patient comes to us for transplant, already listed for LT, we prepare the donor, keep the donor on standby for immediate OT if the condition worsens. In the meantime, if the child has intractable raised ICP despite medical management, then we don't wait. We proceed for transplant, as Dr. Gupta previously said. And other cases, like especially in hyperacute setting, when we are dealing with hepatitis A, supportive therapy for 48 to 72 hours, we let the child allow natural liver recovery, and then we decide whether to go for it or not. And many times we become successful. Next. So this is some of the patients we dealt recently, and in these 6 patients, we can see we implemented all the important criteria like HCHC, PELD, PEDS HAV model, admission LIU score, CALF score, and as we can see, these are not much reliable. Next. Like in these 3 patients, there was survival with native liver, and they all had poor prognostic markers, and despite of that, they survived. We saved them from liver transplant. So do we really need this scores? This question needs to be answered. Next. Talking about liver assist devices, there are a lot of things that propagating use of liver assist devices like CRRT, plasma exchange, and everything. But we really need to see what's the actual indication. Like if you're dealing with Wilson, using plasma exchange is okay. But for other cases, it needs to be discussed. Like CRRT, it is indicated with renal dysfunction if there is AKI or something else. But just for the sake of removing ammonia is little controversial, because as I have experienced in Japan, they use very high flow rates, like filtration and dialysate flow of more than 100 to 200 ml per kg per hour, which is very high. If we use it in our setting, it will be difficult them to be, keep them hemodynamically stable. And another issue, as Dr. Gupta discussed, that pediatric kit, the kit blocks. The kit get blocks too easily, and using an anticoagulation is always a question. If we use heparin, it has systemic side effects. If we use citrate, it has hypocalcemia and all. And the nafamostat is not available in India, which Japanese and other centers are using. So it becomes a difficult and becomes a financial burden on the family if we are continuously going for the CRRT despite a proper indication. And talking about plasma exchange, as rightly said before, discussed already, INR cannot be used for prognosis after initiating this modality. And a beautiful article published last year, 6 months back, from a multicentric study from Europe in Journal of Hepatology, which clearly says the effect of plaques on survival outcomes outside of clinical trials is not yet well established. Next. We do not routinely deploy any LEDs. Next. This is the study I'm talking about. Plasma exchange does not improve overall survival in patients with acute liver failure in a real world cohort. It includes all the 7 major centers in UK. Next. Next. So some pediatric studies have shown improvement in coagulation profiles with plaques, but not necessarily in transplant-free recovery. This is a statement from ASLD. Next. And this is evidenced by a recent meta-analysis published this month, including 12 pediatric ALF studies, including 310 patients, that using high volume plasma exchange leads to transplant-free survival in only 13% and overall only 33%. So it's still debatable whether we should use plaques or not. Next. So as we know, next, there's always a question whether to go to try medical management. And we all know, as an overzealous early LT may devoid the patient of chances of native liver survival, especially in pediatric population who have a very good regenerating potentials, while a delay makes the patient non-transplantable if the patient goes on to develop sepsis or irreversible brain damage. And they should always be given a chance because kids are not like adults. They have a long life to live. Next. This is the same study which I quoted initially. In this study, we had almost 40% patient who had survival with native liver. And we do not use any LEDs as plaques or CRRT routinely unless indicated. Next. Next. In this study, high arterial lactate and prolonged J interval came out to be a poor prognostic markers, and we all know that. Next. This is another paper we published. Next, where we had these 3 children who had INR of more than 10. Next. And all these kids survived without liver transplant. Although they required CRRT, but the reason was acute kidney injury, not the ammonia. Next. And as per this study, HIV-induced PARF may recover despite poor prognosis. And the benefit of using living donor is that we can actually time the transplant. And the transplant timing relies on clinical judgment, not on a particular marker. Next. So this is our experience from the last 6 years and 7 years, where 32 patients we had of pediatric acute liver failure, 11 were transplanted, 2 died post-LT because of persistent cerebral edema, and 12 patients survived with native liver. That is almost 40%. Next. Next. And here we can see almost majority of the cases are hepatitis A related, and they have a very good prognosis as compared to dengue, ischemic, or indeterminate, where prognosis is not that good. Next. So when to proceed for the transplant? The timing of liver transplantation remains debated, but indicators such as worsening encephalopathy, rising intracranial pressure, multi-organ failure, increased inotropic support, escalating INR, bilirubin, ammonia, just like the delta values we initially talked about, they signal urgency. Next. So PALF is different. Diagnosis depends on age of presentation. Management is guided by etiology, and transplant timing is complex, as we discussed already. The most important thing is lifelong impact must be considered in children. Transplant should not be the easy default. Thank you.
Thanks, Vipul, for a nice talk. Couple of questions that are coming up in the chat box. What about the fluid management? Is it anything different, or there's a lot of third spacing? What do you think is the role of albumin in these kind of situations?
The studies from I think Lucknow, they said that only almost 20% of the ALF kids who have sarcopenia or something, they tend to have this effusion and ascites. And routinely we don't use, we keep the patients hypovolemic and euvolemic using isotonic fluids.
Right.
And we also start enteral feeding. That's the most important part.
Dr. Alvin, anything different for adults?
We normally use a mixed electrolyte solution, which is called the plasma light, which is also gives all the electrolytes and needed for it.
True, sir.
Any experience with B fluid or something of like those kind of fluids
Well,
or parenteral nutrition?
Yeah,
For
I don't
parenteral
get you.
nutrition.
Yeah.
Is the question for me? I got confused actually.
Yeah, anyone. I mean, for both pediatric and adult, I would want to ask both of them.
Actually, we start with enteral feeding with calorie intake of almost 100 kilocalorie per kg per day, a protein of almost 1 gram per kg per day, and we also initiate MVI and other trace elements. And only if the patient is not able to tolerate enteral feeding, if there's a ileus or something, then only we go for parenteral nutrition. Otherwise, as a part of protocol, we start enteral only. Parenteral is not a routine.
Right. So although you have already answered that you're not proponent for plasma exchange,
Yes.
still there is a question which says if someone is not showing any decline in ammonia on CRRT, would you still consider a plasma exchange in these patients?
No, actually, we don't go for plasma exchange. If the ammonia is high, we have other measures to look for, like there must be constipation, or if there is some bleeding, or if there is some infection, or we often deploy things like PAG or even sodium benzoate works nicely in ALF setting. So just for the sake of ammonia, we don't start any extracorporeal assist devices.
Any experience with cytosorb?
Yes,
No,
cytosorb.
not in. Hello. Yes, sir. Yes, sir, please.
Cytosorb has been used in the extracorporeal, especially during the early stage when there is a severe cytokine storm. Otherwise, the use of cytosorb in the late phases is not very useful.
Yeah.
Right. Great. So I think we can move on to the next talk.
Yeah. So we have Dr. Rajesh Day with us. Who's a very important topic, when not to transplant, because I think this is the most one of the most important key things which shows the maturity of the team, of the surgeon, of the entire team actually, and hold yourself and say, no, I don't want to do transplant. So Rajesh, would you present a crisp presentation on this? Thank you.
We can't hear.
Is Dr. Day in the audio? Has he joined?
Can't find him.
So maybe I can do that while he's not here. I can.
Sure. Yeah,
Okay.
absolutely.
That'll be great.
He's not. So when not to transplant, next slide, please. The two situations when not to transplant, where if we think that spontaneous recovery is going to be possible, obviously you should not transplant. Or if you think the transplant is going to be futile. There are two basic broad categories when you should not transplant. Next. And of course, you have dilated fixed pupil for hours, then you will not transplant. Next. But that's a very bad picture because the person not intubated. Then you can have metabolic conditions where, it mimics that the person is, and the diagnosis of brain death in the app, in metabolic conditions is very, very difficult. Next. So when there is hope for spontaneous recovery, if there's a hyperacute presentation, there's no underlying liver disease. For example, if you have Wilson's disease, a background, because time and again, Wilson's disease will present with fulminant liver failure, and you have to keep that in mind. Or there is a known etiology and the trend is towards improvement, then obviously you would like to defer transplant at least till as late as possible. Next. So this is one case here, which was, 41-year-old female, drowsy in day one, high bilirubin, INR high as well, but hemodynamic stable, pupils so obviously here we would, it fulfills all the clinical criteria, and there's background of hepatitis A. Next slide, please. An event, but by day 3 it became clear that the INR was improving, lactate was improving, recovered on therapy, and this is the importance of the dynamic evaluation as first proposed by the All India Institute team. Next. Now, when not to transplant, there can be cerebral edema, which is, very advanced. So on high FiO2, multiple inotropes, high lactate, renal shutdown, or positive cultures. I'll deal with each of them one by one. Next. So now, if cerebral edema have been, so I think Julia Brendan first said that, if you have had pupils fixed dilated for hours, only then you have to, or, not consider for transplantation. And particularly if they've been on multiple inotropes, then obviously sometimes pupillary reaction may not be seen. Or if a CT scan shows, and we've had this situation where we had severe sort of cerebral edema, and we're debating whether we should do transplant or not. Ultimately, we did do the transplant, but the person did not recover from his cerebral edema. And of course, reverse jugular oxygen extraction could help in a situation like this. Next slide. Now, if there's high FiO2, then it's often not clear whether it's a result of toxic necrotic liver. Then, I think at least on 2-3 occasions we've done a recipient hepatectomy and early porocoagulation with dynamic, with the, improvement in all these parameters, and donor can then be taken up. And I think we did this one with once with the RR hospital where Dr. Day was there, Dr. Mukesh was there, and also we sort of, I think Dr. Metu has published this, where he did a recipient hepatectomy, stabilized it, and then went on to do a transplant. Next. If there are multiple inotropes, which are sort of continuously increasing with renal shutdown, not volume responsive, then obviously, we think they're too unstable to transfer to OR, then obviously we would not think of transplantation. Next. If there's high lactate, this may be a consequence of liver failure. I'm not sure whether, not clear when we cannot go ahead just because of high lactate. In ACLF, the lactate more than 5 is a contraindication. Of course, we'd like to correct the hypovolemia and see the lactate improves or not. Next slide. Renal shutdown, completely anuric, when the cause for renal shutdown is not clear. Fluid management will be difficult. And we had few cases of sort of acute liver failure who strangely have recovered on conservative management, but went on to have renal shutdown from rhabdomyolysis. Next slide. Now, this is a more difficult one, which is culture positivity. Obviously, for many years, it's been thought that if the person is culture positivity, then it should not be taken up for surgery. Now, what you have to also remember that liver is necrotic, and infection may clear better after removal of the native liver. So we, as a policy, have not tended to not do a transplant just because some culture is positive. But if you feel overall that the risks of doing a transplant is less, that means cerebral is not advanced, then we would go ahead. But we can discuss this in the question and answer session. Next slide. So in pediatric liver, we'll not go into this because Dr. Vipul has dealt with this brilliantly. Next slide. And so poor outcome, again, if obviously some of the factors I've already covered. Next slide. So when will the transplant be futile? No, really, I think as a sort of summary take-home message, if the cerebral edema is thought to be too advanced, or if the patient is actually already in irreversible shock, then obviously transplant not going to work. So these are two situations, I think, where transplant should not be done. I think I'll stop here because I think Dr. Day is still yet to come, but he'll probably join us in the question answer session. Thank you.
Right.
Thank you, sir.
Yeah, Dr. excellent talk. I mean, I'm glad you put up for Dr. Day very nicely. Just tell me one thing. In the question of when not to transplant, is there a difference from a mental standpoint between a LDLT and a DDLT? Because the moment we think that there's a living donor transplant and this donor who's going to be there, our thoughts are slightly, restrictive. Whereas in a DDLT, if you have superannuation listing and liver is coming, probably I would be more liberal. So what are your comments on this aspect?
Yeah, I think in LDLT, the results of LDLT have improved so much in our country that people expect positive outcomes all the time we do LDLT. And I'm sure you have also faced this in your, whereas DDLT, they are, not so much. So if something goes wrong after an LDLT operation, nowadays we find very difficult to answer the question because as if it's something that we've done wrong. I mean, the a negative outcome after LDLT is not accepted as easily as it used to be in the past. So,
Completely agree. Yeah.
in,
Yes.
so so I think therefore you're right, we'd go ahead with DDLT, but LDLT, I think we have to have a reasonable conviction within the team that the operation is going to be successful.
Correct. Yeah.
Yeah.
Abhijit.
So you rightly pointed out about the fixed dilated pupil, and I'm sure there are situations when you have done a CT, you shifted the patient on the table, and then anesthetist tells you that the pupil is dilated and
Abhidip, we
fixed.
have a case like that. We have a case like that. In the next thing, one of the
Perfect. Sure,
Mm.
sure. So yeah,
Just
I
one.
guess then
I was in Paul Bruce Hospital with Professor Didier Samuel, one of the pioneers in ALF and transplant. And one line I remember he told me once when I was in the preceptorship in his center in France. He said, in acute liver failure, there's nothing contradiction for a transplant if you have a liver donor. So that was a general comment what he wanted to convey to me that you are going to take chances in any case, but yes, in a LDLT, one has to be restrictive.
so as far as a hyperacute situation is concerned, would you still evaluate the donor and keep it ready, or you would wait to see the response of the medical management?
I
Can
think
I
one
answer
would.
that question?
No, please.
Yes.
Or does it give you I think one of the things that we would do, even if we are convinced that the person is going to improve, is that it sometimes take the heat off you, because sometimes they're not able to produce a donor in time. Oh, so then if something goes wrong. I'm just being honest here, so don't you can take up arms with me. But I mean, sometimes the heat is taken off. The pressure then is on the family to have a willing donor, and sometimes we find that. It's not easy to, for a kid, yes, Whipple is relatively easy. For children with acute liver failure, a lot of family members will come forward. But in adult ADLT, I mean, some amount of fatty liver disease or something. So it actually gives you, I think, a breathing time to assess the patient better. Telling the family that, we would be, so we routinely would encourage or suggest that transplant, even if we were sure or not sure. I mean, we reasonably sort of, felt that the patient could improve on spontaneous. Still, we would go ahead and, ask them to be prepared with a donor. So not a very scientific answer, but a very practical answer.
No, actually, it's absolutely needed because when you're first breaking this news, they would need time to think about it. So I think it's absolutely justified to actually tell them that there is a possibility of transplant, and they can start looking and getting a person evaluated. Completely agree with that. So yeah, I guess we can move on to the next talk because I know a lot of people are eagerly waiting to go to the cases. So
Yeah. We have
and
two.
I think the next talk is on the anesthesia management of for ALF.
So Dr. Sumit is our senior anesthesiologist. Again, extremely trained and huge experience. So Dr. Sumit, please make your presentation.
Thank you, sir. Good evening, everyone. Yeah. Good evening, everyone. I will be talking about anesthetic management for liver transplant in acute liver failure. Next slide. The shifting of ALF patient from ICU to operating room should be done with utmost care. There should be proper communication with detailed handover between intensivist and anesthetist for the continuation of care during intraoperative period. Portable ventilator should be used for transportation to avoid any hypercapnia with maintaining head and elevation. Adequate sedation, analgesia, and muscle paralysis should be ensured to minimize chances of patient bucking or cuffing on endotracheal tube. Due care should be taken of all the vascular accesses and vasopressor infusions to prevent any cardiovascular instability during shifting. If preoperatively managed with CRRT in the CRRT, the decision to continue it during the intraop period has to be individualized on the case basis. At our center, intraop CRT is not preferred. Next. In our institute, CT scan head is done prior to shifting the patient from ICU to the OT to rule out any raised intracranial pressure or intracranial hemorrhage. The advantages of pre-op CT is that it is rapid and easily available and has very high specificity. Next. The perioperative goals of management in ALF patient are to maintain cerebrovascular stability, systemic hemodynamics, perioperative fluid balance, acid-base balance, metabolic and electrolyte hemostasis, and finally coagulation balance. Next. Now coming to anesthetic management, usually these patients are on mechanical ventilation. But if patient is not on mechanical ventilation, adequate depth of anesthesia should be ensured to attenuate any rise in ICP associated with the stimulus of laryngoscopy and intubation. Primary volatile anesthetic agents to be avoided as they can cause cerebral vasodilatation. Propofol infusion has to be used as an adjunct to the inhalational agent as it reduces cerebral metabolic rate, cerebral blood flow, cerebral blood volume, and intracranial pressure. And propofol also has an anticonvulsant property. Next. At our institution, expeditious clamping of portal vein is performed for native liver hepatectomy and temporary portocaval shunt is created. Rendering the patient anhepatic helps to stabilize the neurological and cardiovascular status of the patient by controlling the SIRS response, as the patient's own necrotic liver is a significant source of pro-inflammatory cytokines causing cerebral edema and multi-organ failure. Next. These patients are usually hypovolemic because of the SIRS associated with profound systemic vasodilatation, capillary leak, and insensible fluid losses. They are also hypovolemic because of poor oral intake, vomiting, and encephalopathy prior to admission. Next. Hemodynamic targets. Our goal in ALF patient is to maintain the ICP below 20 to 25 millimeter of mercury and maintain cerebral perfusion pressure above 60 millimeter of mercury. In the absence of advanced HE, target map is 65 millimeter of mercury, and in advanced HE, the target map is 80 millimeter of mercury to ensure an optimal cerebral perfusion pressure. Norepinephrine is the preferred vasopressor. Theoretically, vasopressin can cause cerebral vasodilatation and thereby exacerbating underlying intracranial hypertension. Next slide. Mean arterial pressure more than 140 millimeter of mercury or intraoperative hypotension with systolic blood pressure less than 90 millimeter of mercury may also be the risk factor for acute brain swelling. Mean blood pressure fluctuations and large blood transfusions were intraoperative predictors of short-term mortality after LDLT due to ALF. And once the patient becomes unhepatic, the hemodynamic rapidly stabilizes because of the exclusion of the vasoactive toxins from the circulation. Next. Fluid therapy. Hypotonic fluids like 5% dextrose should be avoided as it can induce osmotic shift in intravascular and cerebral compartment. For hypoglycemia, large volume of dextrose containing fluid should be avoided. Hypoglycemia should be managed with 25% or 50% dextrose infusion separately. And also we should avoid hyperglycemia as it can exacerbate raised ICP. Regarding hypertonic saline, fluid resuscitation and hypertonic saline infusion should be targeted to maintain sodium between 140 to 145 millimoles per liter. Rapid change in sodium level should also be avoided and correction should not exceed more than 10 milliequivalent per liter in 24 hours. Next. Coagulopathy. Just like in CLD patients, the coagulation management is guided by the use of viscoelastic tests like TEG and ROTEM, not by standard lab test. Although these patients have a very high INR, but TEG tracing shows normal coagulation or even hypercoagulable state. Absence of long-standing portal hypertension and portosystemic collateral leads to reduced intraoperative bleeding. If required, the use of fibrinogen concentrate and PCC can be considered in ALF patients with AKI. Next. The most important part, neurological monitoring and management. While the dissection and reperfusion phase are associated with increase in intracranial pressure and decrease cerebral perfusion pressure, but thankfully, anhepatic phase shows decrease in intracranial pressure. In operating room, the head should be maintained in elevated position and neutral position. For ventilation, lung protective strategies should be used, hypercapnia to be avoided. Target PCO2 level is 30 to 45 millimeter of mercury. And there is no role of hyperventilation in routine situations. It reserved only for emergency rescue situation. Next. Temperature regulation. The target temperature should be between 35 to 36, core body temperature 35 to 36 degrees Celsius. Also avoid any hyperthermia or fever. There is no routine role of hypothermia. It is reserved only for refractory intracranial hypertension. For osmotic therapy, mannitol and hypertonic saline can be used. For depth of anesthesia, BIS monitoring to be used. And also we should observe neurological signs like pupillary abnormalities, unexplained hypertension or bradycardia. Next. Now coming to ICP monitoring, although invasive ICP monitoring is considered to be a gold standard, but it is no longer considered to be the standard of care. Many non-invasive modalities have gained popularity for intraoperative ICP monitoring, but needs to be validated in these set of ALF patients. Next. Multiple non-invasive modalities for ICP monitoring are available, but all have their advantages and disadvantages. Next. The important ones are optic nerve sheet diameter, transcranial Doppler. Next. Pupillometry, near infrared spectroscopy, jugular venous oxygen saturation. Next. Multimodal neuromonitoring. At CLBS, preoperative use of ONSD, pupillometry, and BIS for ICP monitoring is continued intraoperatively. Next. Now coming to the use of intraoperative CRRT. The decision of continuing CRRT intraoperative needs to be weighed against its limitation in addition to the limited experience of the anesthesiology team. Anticoagulation with heparin is not recommended, but citrate can be used. The problems of circuit like clotting, kinking, or malfunctioning, or the problems with extracorporeal circulation like increased infection risk, hypothermia, thrombocytopenia, and coagulation abnormalities should be considered. Also, the effect of CRRT on the intraoperative drugs dosing that undergo renal excretion should also be considered. Next. Now coming to post-op management, despite a normal functioning graft, delayed recovery in the post-op period is expected. Cerebral edema leading to encephalopathy takes time to recover. Post-operative ICP monitoring in form of ONSD, pupillometry, and BIS should continue pending documentation of resolving cerebral edema. At our institute, we have protocol of elective ventilation for at least 48 hours in post-op period with continued ICP monitoring. Next. Thanks for your attention.
I thought that was really brilliant.
Thank you, sir.
Thank you, Dr. Sumit, for a concise talk. You said you don't prefer CRRT intra-op. Is there a reason, or particularly in those patients who were already on CRRT before?
We have been able to manage the preoperative patients who are on CRRT. We have been able to manage them intraoperatively without CRRT because there are many concerns with intraoperative CRRT, hypothermia, coagulation abnormalities, thrombocytopenia. So we were lucky and we have been able to get the case done without intraoperative CRRT.
I will just add on to that.
Yes,
May
sir.
I? We're not
Yes, sir.
in context with the ALF, but we do a lot of patients nowadays with complete renal impairment. And in fact, I mean, we probably have the largest series with Dr. Sanjeev and me as supposed to write it up someday. And we found that intraoperative CRT is actually a cumbersome thing. And so a short operation and then you do it before and after is probably better rather than doing it in the theater, which is already jam-packed with equipment, CT head scanner and then monitoring machines and devices. So it's really, I think the whole thing has been to simplify the operation to get the best results. But we can discuss. I know the groups, I think Dr. Vijay Vora is very fond of intraoperative CRRT, from what I know. But I think as a group, and we published this, I think on ACLF at least, that intraoperative CRT is really not needed to manage them within the theater. But of course, if there were crises, if somebody potassium shot up and you had no choice, then that's a different matter. But routinely using CRRT in theater, probably not right.
So this brings another question. Would you restart CRRT in post-operative period? And if yes, till when?
There is an interesting situation in ALF patient. Many times after hepatectomy, the patient starts urinating. So in case if a patient urine output, we get an adequate urine output, then we don't start in post-operative period. But if there is no urine output, then we restart in the post-operative period.
Okay. And what is the target range of blood sugar?
Between 120 to 200, not too much, not too tight control.
Okay. And there's another question which says, do you use dexmedetomidine?
No, we don't use intraoperative. We haven't used dexmedetomidine. We are
But
quite
in
post-op,
comfortable
we
with
ICE
started using a lot nowadays, isn't it?
Yeah, at the
Post-op,
ICU, we
So ICU, you use dexmed.
Yeah.
Post-op, we started using a lot.
And what is the sedation protocol before transplant? Dr. Arvind, you can answer that.
Before when the patient is posted for liver transplant, we use
Yes,
pre-medication.
before
Consisting
dexmed or
of,
midazolam.
we don't give any dexmed during the before the pre-operative period. We use proton pump inhibitors and not even the benzodiazepine. Yes, before induction, we can give a small dose of 0.001 to 0.02 milligram per kg midazolam.
Okay.
Should we move to the next talk? Abhijit?
Yes. Let's move on to the next topic.
It's a short talk by Dr. Mukesh, who's again a very senior surgeon with an interest in robotic surgeries, if I'm not wrong. And following this, we'll have two case presentations, I think, which everybody is waiting for. So, Mukesh, can we have your case presentation?
Yes, sir. Am I audible?
Yeah, you are.
Good evening, all. So I'll be talking on surgical technique in liver transplant for acute liver failure. Next, as a liver transplant is a definitive treatment for the patient who are not recovering from acute liver failure. So I'll not go into details of definition and indications. So optimal timing of the liver transplant remains the next slide, remains the challenge, as too early transplant sometimes is unnecessary and too late transplant gives poor outcome. Next. So first step to optimize the patient as much as possible, but in a case of ALF and rapidly deteriorating condition, it is very difficult sometimes. And so quickly do the native liver explant followed by benching if required in the case of right lobe donation, and then sequential anastomosis reperfusion and followed by hepatic artery and bile duct and adequate hemostasis on table so they don't bleed in the post-operative period. Next. So what are the challenges in liver transplant for ALF? As liver transplant is the known treatment for ALF who are not recovering spontaneous, has its own issues, and team should be expert enough to deal with it in the rapid manner, as there are tight time constraints for surgery due to patient rapidly deteriorating condition, increased risk of bleeding due to coagulopathy, potential for severe hemodynamic instability, difficulty in assessing donor liver suitability and managing cerebral edema from HE, and precise surgical technique to minimize complications, and ethical dilemma of the balancing the urgency of transplant against the risk of unnecessary surgery who might recover without transplant. Next. So, orthotopic liver transplant is the preferred modality, followed by the APOLT, especially in the PCM poisoning and metabolic liver disease, causing acute liver failure. As this is out of the hour surgery, so expertise should be available, which is difficult at late hours surgery when it is happening, and care should be taken to prevent the cerebral edema, as the routine CT head we do routine CT head while shifting to OR to check for the cerebral edema. If it is grossly edematous, fixed, non-dilated pupil, then surgery might be futile. And quick recipient explant, minimize blood loss, short cold ischemia and warm ischemia time, and avoid cross clamp of the KY possible, as many of these patients are already having renal dysfunction. Next. So for the surgery, bilateral subcostal incision with upper midline T extension, rapid explant to prevent cytokine storm and toxic liver syndrome, and looping the portal structure directly, and then dissecting it and separating all the hilar structures, and If hepatic hilum is frozen or difficult to dissect, then vascular clamp can be applied, and hilar structure can be cut and masse and to be separated later on, and portal vein mobilized and to do the portocaval shunt and rapid explant and rapid hemostasis to prevent further insult to the patient. Next. So portocaval shunt we routinely do in these patients as recipients are to be taken first because in ALF patient they don't have a portal hypertension, so chances of bowel edema are higher. Then later on they might have a difficult closure and due to gross bowel edema, and sometimes mass has to be placed. In this figure you can see we have done the portocaval shunt with the portal vein with the middle hepatic vein. It can be done directly to IVC as well. Yeah, next. So many times when a patient are too sick and you are not able to decide we should go ahead with the transplant or not, and after proper counseling the patient, you can do two-stage surgery where recipient explant is done first, and when patient are if patient improve, then you can go ahead with transplant as published by Dr. Reddy and et al. And I was also part of this two-stage surgery in RR hospital where we did explant as patient was from shifting ward to OR suddenly deteriorated. FiO2 became 100%, and despite that SpO2 was 90%, and inotropic support in the form of a NORAD went up to 30, and he was too sick. After explaining the patient, we did a recipient explant and shifted back to ICU, and then patient improved within 10-12 hours, and FiO2 became 50 and NORAD came down to 10 ml per hour. So we did transplant after approx 18 hours. Yeah, next. So for the venous reconstruction, conventional KVA replacement can be done in a DDLT setting and piggyback in DDLT or LDLT. Care must be taken for the tension-free anastomosis, anatomically oriented, no kinking or torsion should be there. Lumen should be widely patent, suture line should be hemostatic. And nowadays we are routinely using growth factor even in anastomosis for right hepatic vein, so they don't have a problem in the post-operative period in the form of graft outflow obstruction. There should be no redundancy, and careful IHV reconstruction should be done, which also helps in the positioning of the graft in a narrow and less spacious cavity in ALF. Next. So in this figure, you can see to decrease the warm ischemia time, we are doing the IHV venoplasty with the RHV for the single anastomosis. Next. So here we had a emergency situation like where donor was worked up and RHV was draining into the middle hepatic vein, which was quite challenging. So there we did donor hepatectomy, and the IHV, right hepatic vein was directly anastomosed to the cava. And for middle vein reconstruction, we use PTFE in this case. Routinely, we don't use because they tend to have erosion in the stomach or blockage risk. Yeah, next. For the anterior sector drainage, we usually prefer portal venous, explant portal venous graft. But in this case, in the first figure, you can see as it was not usable, so we were using hepatic vein as a graft to reconstruct the neo-MHV. And the second figure, we did implantation, and on Doppler MHV was not working because of less flow in the segment 5 vein, so clot was getting formed. So we directly anastomose the segment 8 vein to the middle hepatic vein, and for the segment 5 vein directly to the IVC. And in the post-operative period, this patient did well, and the vein from the segment 8 did not get blocked because sometimes the when low flow in flow state in segment 5 vein can cause thrombosis. So yeah, next. So portal vein should be well mobilized and flushed with heparinase careful handling to prevent the intimal injury, to prevent the portal venous thrombosis. In LDLT already graft portal vein is shorter. So anastomosis is performed in end-to-end fashion, and sometimes end-to-side anastomosis in uphold and ensuring tension-free anastomosis to prevent the kinking and stenosis, no backwalling, no redundancy. And in pediatric transplant, we use a patch from the right portal vein and left portal vein to match the size of the graft and growth factor as well to prevent the narrowing. Next. So, as in ALF, we don't have time and it's an emergency surgery. Sometimes we have to accept the patient donor with the available donor. In this patient, we have two portal veins. So we did backbenching and two portal vein made into one as it was a type C vein. Yeah, next. So arterial reconstruction, both the arteries should be mobilized properly and there should not be tissue around the artery, and 80 proline is used, and we routinely do right wall first after taking anterior and posterior stitch and then do the left wall, and care should be taken to avoid excessive tightening of the suture which can lead to narrowing of the lumen and suture can get cut through, and flushing with Hepsaline should be done before completing the anastomosis. Next, to prevent the arterial. Again, here we had to use a posterior sector graft due to availability of this donor only, and there was a short right posterior sector artery as we took right posterior graft, so we had to do back benching and use arterial graft for the extension. Yeah, next. So biliary reconstruction ideally should be done in duct to duct as the bowel is very edematous, but in a pediatric patient we had to do HJ as well sometime, but duct to duct is preferred when it can be done. Yeah, next. So check cholangiogram can be done after this biliary reconstruction to check for the narrowing or leak. Next. So Apult is an interesting modality which can be used in acute liver failure many times, as many of these liver can recover after the surgery. And this requires both the graft and recipient liver to be reduced. In recipient procedure, a frozen section biopsy of the native liver is usually sampled to assess the absence of fibrosis or massive necrosis. And right or left hepatectomy of the native liver is performed in order to prepare the space large enough to accept a right or left liver graft respectively. In this procedure can be used especially in the patient when acute liver failure due to PCM poisoning or metabolic disorders in pediatric children, pediatric population. Yeah, next. So here you can see native right side of first figure, right side of the liver, native liver is preserved and left liver graft is being used, and in other figure, modified right liver graft is used and preserving the left liver lobe. Yeah, next. So outcomes of transplant. This study done by Japanese group which showed ALF with coma. Liver transplant showed survival of around more than 80%, but without transplant, these patients survival were around 39% in subacute, 24%, 7%, but surgery gives around 80%, more than 80% survival. Yeah, next. So many factors there.
Because you could skip that because of the time
Next,
paucity. Yeah.
next.
Yeah.
Next, please. Next, please. Yeah. So our experience in ALF, we have done till now 68 patients starting from 2007 to 2024. Out of that, 67 were LDLT and one was DDLT. And out of 68, 37%, 37 patient, 54.4 patient were on mechanical ventilation before transplant, and 42.6% patient were in grade 3 or 4 HE. Next. So,
Just summarize. Just summarize.
yeah, MELD average age was 23 years, and more of the patient were male. MELD score was 35, total bilirubin was 19.9, AST and ALT was 793 and 884, and INR was 5.9, and creatinine was 0.7. And next, HAT incidents were 4.4%. No, we didn't have any PVT. MHV thrombosis in right lobe happened in 2 patients, and re-exploration was done in 13 patients. And sepsis was in 10.2% patient, and 8 patient required reintubation, and retransplant was done in 1 patient due to HAT. And biliary complication we had in 22.05 patient, as these patients have higher biliary counts, and we had 17.6% mortality with 1 year survival of 81.1%. Next, this Kaplan-Meier curve showing 1 year survival is around 80% and 5 year survival around 70%. Next. To conclude, successful surgical management in ALF liver transplant depends not only on the technical excellence but also on the integration with perioperative critical care, including management of cerebral edema, coagulopathy, and multi-organ response. And by combining meticulous surgical technique with advanced perioperative support, liver transplantation offers life-saving treatment and the best chance for survival in this patient with acute liver failure. Thank you for the patient hearing.
Thank you, Mukesh. Thank you for a concise presentation on the surgical technique. I think in view of the time, let's quickly move on to the cases.
Absolutely, yeah. So the 2 cases which are coming, so we'll have, because Abhidip tells me that we have a time restriction. So let's see how much best we can do. So the cases first is by Srijit to present his case. In the audience, senior hepatologist surgeons who are there would welcome, or intensivists, anybody to welcome. We might invite you to make comments on these cases so that we have a different view on what was the right thing or what is not the right thing which we have done. So Srijit, can you start your presentation, please?
It's a very good evening to all of you. Am I audible?
Yeah.
Yes.
Yeah. So very good evening. So I'll be giving a short case scenario. This child, who 6.5-year-old male, he presented almost 3 weeks back to us. So he presented with there was a history of fever and abdominal pain, some back, and subsequently he developed jaundice. It was 3 days. There was increased compatibility and altered behavior. So the duration between jaundice and encephalopathy was almost 12 to 14 days. And his biochemistry showed a bilirubin of 14 with INR of 10 with normal renal functions. And the etiology was not known. All the etiological markers were negative. So who are in the they can comment what would be the plan of action when we encounter such situation. So the diagnosis, we know that it is clearly acute liver failure, and the duration between the jaundice to encephalopathy is almost 14 days. And we don't have an etiology. So when such a child come to us, what would be your plan of action? Dr. Vipul, are you on board?
Yeah, okay. Whenever these cases present to us, first of all, we have to stabilize them. We have to assess their grade of encephalopathy, and we have to intubate if it is advanced. The most important part to manage is the raised ICP. We have to monitor and manage that part. After that, after starting all the maneuvers, whichever we do, like anti-ammonia measures and anti-raised ICP, ventilation, everything, then we have to start the hydrological workup. It's quite important. In this case, as you already told that it was negative, so initial tests are always hepatitis and all, hepatitis A, E being the most common, followed by non-hepatotropic viruses. And if it is still coming negative, then there are some causes like dengue or some local infection, autoimmune Wilson. There's a long list that goes on. But in this case,
okay,
actually,
so
everything was negative.
In this case, because the etiology was not known. Yeah. Next slide, please. So obviously the child came to us in an intubated state and with a grade 3 HE. And all those anti-coma measures, anti-HE and brain protective measures were started. To begin with, the child had a decent map, a normal map rather, and subsequently the child started to deteriorate. The initial INR was like 5.7, and after 6 hours it rose to 7.5. The child also had history of the child was initially managed in a tertiary care center where the child was subjected to 2 sessions of plasmapheresis as well. So as as we see, so obviously the child was intubated, and as you have discussed and as we have also discussed, whenever the ALF patient comes to us, we counsel the family with regard to liver transplant, because we cannot say when the child or when the patient would deteriorate, and we keep the donor ready and all the workup ready, and if they are willing, when the child or when the patient deteriorates, we proceed to transplant. So I would like to ask about the therapeutic. What are the views on therapeutic plasma exchange, and what are the chances of recovery with regard to therapeutic plasma exchange? Dr. Sehgal, Dr. Gupta.
I would rather request if Dr. Jyotimani is around from Redline Institute. He's a very experienced, a dear friend. Are you around, Dr. Jyotimani?
Yeah, Sanjay, I'm here.
So it will be really wonderful to have your comments on this, because you have a vast experience and you are among the top pediatric transplant centers in the country. So what do you do in a plasma exchange CP? What is your practice?
Pediatric transplant. Pediatric is a separate team actually.
I know,
So Dr.
Naresh is there,
deals with that.
But what are
I
your
can only
views
talk
on
Let's
about-
assume
therapeutic
he's
plasma exchange in an
16
acute
years
liver
old.
failure?
This man, this patient, 16 years old, 18 years old.
Okay.
Yeah.
So what's the question now?
General comment on TPE.
Yeah, in an acute liver failure with an INR of 10, ammonia of 280, like when would you consider, like if at all you consider therapeutic plasma exchange, like or bar CRRT, when would you consider? That's it. What are your views on that, Dr. Jyotimani?
You are on mute, Dr. Jyoti.
Can you hear me? Yeah, sorry. CRRT indication in ALF is actually not kidney injury, is hyperammonemia. Okay. And if you look at the studies, particularly one published in 2018 from Carlos, ammonia more than 140 or 150 is associated with poor prognosis. It is associated with cerebral edema. It's a risk factor for development of cerebral edema. So therefore, when we manage patient with ALF, it should be a goal-directed therapy. Okay, say your goals are: one, to sort out your cerebral dysfunction, metabolic acidosis, organ failures, and sepsis. These are the 4 goals you should focus when you deal with ALF patients. The CRRT, I know there's been a different opinion earlier, but we start CRRT early. Early CRRT has been shown to improve outcomes because it reduces ammonia and it reduces the risk of cerebral edema in these patients. And again, so that's what we do actually, CRRT early. And plasma exchange, yes, we do here because here the INR is 10 and definitely we'll go for plasma exchange. The question is, what is the cause of ALF? If it is hyperacute, there is high chance it will recover with medical therapy. Therefore, we should be aggressive in this patient. So definitely INR of 10 and 280 of ammonia definitely will start CRRT. However, in children, it may be a little different because they don't develop cerebral edema that common because what I was told is a soft skull. So I don't know the parameters in pediatric age group. Definitely in adults, we'll start CRRT. At what level? It's usually above 120 like that because 150 is a cutoff for us. Where things will start going. Yeah, plasma exchange definitely for this INR of 10 definitely will start because what plasma exchange does is obviously it brings down the bilirubin and also some of the other inflammatory parameters of SIRS, which is very high in patients with acute liver failure. So therefore, yes, we will start.
So you would do both CRRT and plasmapheresis?
Correct. So start them on CRRT first because what is going to kill this patient is cerebral edema here. Ammonia of 280 is very high. So start them on CRRT and then, you can, after 24 hours, you can start them on plasma exchange. It is CRRT that is more relevant here than plasma exchange in this scenario. There is more evidence for CRRT in acute liver failure than plasma exchange and not SLED.
Dr. Charles
some
here.
of the
Yeah, Dr. Charles, what are your
Charles,
thoughts on this?
Yeah, so Dr. I just wanted a clarification. Here you see that encephalopathy 2, and the onset to encephalopathy time is more than 2 weeks.
Yeah,
so
it was
would you
like,
still do a plasma exchange here?
It was 12 days. so the therapeutic plasma exchange was done from elsewhere. I mean, the child was getting treated from a tertiary care center.
No, I'm just asking Dr. Dinesh in his center if now that it's 14 days from onset of the jaundice to encephalopathy, would you still consider plasma exchange or directly go for consider for a transplant and go for a transplant?
Can I also make
Dinesh.
some point?
Yeah, Rakhi, please, yeah,
Yes,
carry on.
Yeah.
yes, ma'am.
So
Sure.
we do a lot of plex for patients. I would say clear-cut transplant, two criteria. If single criteria of KCH, so INR above 6.5 with cerebral edema, our experience is 85 to 90% mortality. So there we do plex and CRRT as a bridge, like they're getting donors and they need to buy time to maintain the patients and not let them go into refractory ICH or not getting tubed will be better. So those things are important in the context that we are preparing for a transplant. So these two criteria in our experience, not the KCH 3/5, but KCH single criteria of INR with cerebral edema, 85 to 90% mortality and straight away transplant. And plasma exchange
That's
only as a
right.
bridging therapy to transplant.
CRRT and plasma exchange, it's as a bridge, not to replace transplantation. Yeah, because the patient has been
Like
more
you
than 2
said,
weeks.
Dr. Dinesh, very rightly, like you said, we do not have experience on pediatric. This is not a statement for this particular patient, but I'm talking about adults because we manage adults and I do not know the pediatric experience of INRs of 10 and all this. And the other thing is that the window, like for adults also, which patients will recover. So cerebral edema, even if INR of above 6.5, hepatitis A and hyperacute, we see high mortality. That's why these two criteria are very essential. The other criteria, like etiology wise, if it is hepatitis A and hyperacute, even with cerebral edema, almost 70 to 80% with CRRT and combination of plasma exchange, many patients will come out even if they are meeting the 3/5 criteria of KCH, INR in the range of 3.5 to 4. And the only problem is introduction of sepsis with PLEX. PLEX is a very effective therapy. CRRT is a much safer modality. But the only concern is we should not introduce infections, lung problems, which again become a challenge for the transplant surgeons and the team. So our concern is we give broad spectrum antibiotics, and that is why the question was asked. So broad spectrum antibiotics, antifungals, cover them effectively and do plexed. So in this particular patient with grade 2 HE, I would have also done a CT scan to screen for early cerebral edema. So the patient has not slipped into HE. So that is also very helpful because then we can be more aggressive with the CRRT and our therapies of extracorporeal therapies because we know we are dealing with cerebral edema.
The other benefit of CRRT is actually it also reduces a lactate.
Yeah, so
If
in
you
this
look at the
particular
original
patient, the
study.
entire LFT is something which is important. The parameters of non-invasive ONSD, sugars, phosphate, all this gives us indirect measures of how well the patient is regenerating and how fast we have to counsel for a transplant. So INR in my experience has been the most effective parameter.
So can we take can the take-home message? Sorry, can the take-home message be that now that it's 2 weeks from the onset, so mostly the plasma exchange and CRRT are going to be a bridge to transplant?
Yeah.
And yeah.
So we can do it as a bridging, and we should do. We should not let the patients wait and deteriorate. We should do extracorporeal therapies, but the goals should be an early transplant. So the donor has to be made ready and everything.
Yeah, so my question is, again, I know we're running late, but just very quick question. Now, Charles made a comment that it is a bridge to transplant late, right? So if I have a patient in my ICU who's like 2 weeks, no, he's been late onset, this thing, he fulfills transplant criteria. There's a donor available and family is very keen for transplant. So in that situation, why would I like to have this modality which might introduce sepsis? If I can have a modality which can say, this is going to reverse my ALF, it can lead to regeneration, then I will be more keen. But if it's only simple bridge and if the donor is available If there's no donor,
Yeah, donor is available, sir, upfront transplant. That is what I'm saying.
Yeah.
But if the donor is not available, then we are doing these therapies as a bridge to transplant.
I think we're
That's the
discussing.
message.
So in the interest of time, we can.
Please.
Yeah,
So we
so
recommend the upfront transplant if possible.
Yeah.
Okay, so we counsel the patient, we counsel the parents for transplant, and the father was the was the prospective donor. The issue with the father was there was mildly increased SGOT, SGPT with a BMI of more than 30, and his MR fat fraction was 15%. There's no other donor. So, how confident are we in taking such a donor for an ALF? That is my primary question.
Child.
And second,
remember which
for
we'll
the
be
child.
using the left lobe.
We'll be using the left lobe for this child, and if at all we enroll the patient for super urgent listing, so what are the chances of getting an organ in this situation?
All very important questions.
Dr. Charles, what are your thoughts on this?
No, at least in our center, fat fraction is only 15%, and if GRWR is 2, then we would definitely go ahead and do the transplant.
Okay. Dr. Jyoti, Dr. Rakhi, what are your thoughts?
Our center is very, very strict with respect to donor selection. For such patients, we would do a liver biopsy to find out what is the donor status. We do not
So do
take
you
such
have
patients.
with an increasing INR of 5 to 7 to 10, do you have time for a liver biopsy? Or
anyway, she's
So that is what we are saying. In a government sector, we are very strict with respect to selecting the donors. So that is where we use the extracorporeal therapies to make the patient and not let him get sick. Yeah.
No, here we are not concerned about the donor safety. We are more concerned about saving ALF patient. So we are taking the left lobe.
Because we'll be taking the left lobe, no? It's not a right, left.
So in
left
this child,
we are taking a left lobe. We are not concerned about donor safety. We are more
probably
concerned
left
about
lateral
saving the child.
segmentectomy alone, isn't it?
So I'm just saying, because ILBs, whatever we are practicing, I'm just saying how we do at our center.
Yeah, I agree. We will move on to the next. Another question. This is rather Dr. Chidich is not stressed on this. I mean, we often find, I'm on the Apex technical committee as well, that these patients are super urgent listed. But is it really, does it ever result in organ allocation for a ALF, or is just something that we,
So in Delhi, though, we are not getting any organs.
Yeah, that's why.
No,
organ.
in Chennai, it's not that bad scenario. Yeah, when we list, we do get organ allocation, but it may not be on time. You know, this patient, when you talk about INR of 10, and so he is really racing against time here. So you may not get on time the liver, maybe but definitely the chances are better here. Actually.
So with deranged LFTs, whatever it is, I mean, what is the final take-home message? Are we okay to take this donor with a deranged LFTs and BMI, say 35?
Deranged LFTs, Bidip, it's, often you'll find OTPT instead of 30,
it was like in the 50s and 60s rather.
Yeah. And you really, in the normal setting, you would ask them to reduce weight, diet and all that. 2 weeks, most of them will correct. But here, what do you do? I mean, it's a dilemma. It's a day-to-day problem.
If it's more than 2 times, then I'm very hesitant.
So that is what, I mean, the take-home should be, if it is more than 2 times, and biopsy, no biopsy.
Biopsy,
technically, so you can do a biopsy and get a result in 12 hours. But I tell you, I mean, it's really, toughest thing to do in a ALF situation. So here, Raki's point.
Fibroscan?
Well, you can go for a frozen section biopsy as well.
So we've done that actually, but frozen does not give you inflammation. It tells you the fat content.
Yeah, fat
Vedanta. I realized that frozen is not at all good for the inflammatory things. Like if you want to diagnose ballooning and all these things, you cannot see it so well.
And
so
my
anyway,
oncologist told me that frozen section overeats fat.
You are totally right. That's right. Yeah. Okay. Great. So
we'll next slide, please. So we, in this case, because the child and the left lobe was planned, so we proceeded with surgery. So here we have the plan was to go for a rapid explant with the portoconvulsion, which we did. And interestingly, what Dr. Abhideep has just mentioned, what we saw was that our anesthetist pointed out the child had a mid-dilated pupil which was non-reacting. Next slide, please. Next slide. So in the donor, so there was no irreversible step was done. And so in this situation, what next? Should we abandon the procedure, or we go ahead with in this difficult situation? Dr. Abdeep, what are your thoughts? We have completed the transplant, no irreversible step. There is a mid-dilated pupil which is not reacting to light.
So these temporary phenomena do happen in these patients, and there are patients who are shifted on table, and at times you start the surgery and these phenomena happen.
Go ahead,
but you should not take a decision immediately.
Very wise.
Go ahead, which we did.
Yeah, the same thing which we did. Any difference of opinion in the among the group, or
the adults it might be
Dilated
different.
pupils have reversed, so it's like
No, adults it might be different, but children definitely will go ahead.
Yeah.
Okay, so same thing. So we went ahead with surgery. So we did, next slide please. So we took a left lobe graft. We proceeded with transplant. It was a father left lobe graft. Cold ischemia time was 60. GRWR was more than 1. 30 was a warm ischemia time. Next please. Next slide please. So in the postoperative day 1, the pupil still not reacting, but not dilated, but still not reacting. So what would be the approach in this case? Stop sedation. It's just post-op day 1, like within 20, like just completing 24
in the
hours
post-op period, not just day 1. When do you stop sedation to assess neurological?
Stop sedation, assess the neurological status.
When do you do?
Or when do you consider early tracheostomy? Dr. Rakhi, Dr. Jyoti.
Rakhi, Dr. Abhideep, anyone can answer these. These are the practical.
we can, what we do, we look at non-invasive parameters of brain assessment to make a decision about stopping sedation. So we can have some, because this is not an absolute criteria. So we may do a EEG, we may do some ONSD and something. If everything is fine, we should stop sedation and assess.
The bottom line is, I've seen, individual ALFs like this. The point is that take-home thing is that post-surgery in ALF, 24 hours, just leave them alone.
Don't more than 24 hours.
Don't try to assess their
more than 24 hours.
Yeah, exactly. Don't touch them. Let them have a normal, whatever body is doing. Don't challenge them with stopping sedation and try to say no status. See that 24 hours, 40 hours, you might find that guy wakes up on the third day. So don't worry. If everything's okay, just go on.
And that will depend, sir, also on the pre-op status of the brain. If the patient has severe cerebral edema, he may take a longer time.
Once you have done
he
the
or she may,
you have done it. Just forget it. Just
So,
give them time.
Quick question to everyone. How many of you check ammonia post-op, and how many of you would consider CRRT in these kind of patients?
I won't check post-op ammonia.
Post-op ammonia is the most unreliable measure. Value
ammonia is affected by so.
It will not impact my decision.
Out of the window.
Once a good liver is put by Dr. Gupta, I'm confident things will move.
As a CLBS team, not by Gupta. I don't do any surgery now. Okay.
So, sir, if people are if we are doing intra-op CRRT, then obviously maybe in post-op for 1 or 2 days, it may be continued centers who are doing. And that is what we do specifically if the patient has ATN or some degree of renal dysfunction. Right. So then they may require some CRRT.
But we are not very, I mean, this is a personal bias, not very happy with the CRRT, how it's done or what.
Generally, we continue just 1 or 2 days till things settle down, and then turn off the sedation. Yeah, absolutely.
Okay.
This child woke up on day 5. Can you do quickly?
So the child woke up at day 5. Now it's post-op day 16. The child LFTs have come down, and the child is sitting and having normal diet, normal activity. Yeah, there is some.
Can we quickly move on to the next case? I mean, we'll take another 10 minutes and.
Yeah. So Dr. Shashwat is presenting the next case. Again, a very interesting case, and here it's a non-transplant one. So Dr. Shashwat, can you come on? So you did a lot of challenging things, people not reacting so well. But I think decision here again, is there that your gut feeling is there to go on, you're okay. So Shashwat, please.
Good evening. Thank you for having me. Just because we're running late, I'll run through the case and I'll avoid the topics we've already discussed. Can I move on to the next slide, please? So now we have a different case scenario. This is a 20-year-old gentleman who was very fit. had fever about 5 days prior to presentation, associated with severe abdominal pain, developed jaundice the next day, and then encephalopathy the day after. So just a very short period. And when he comes to the emergency, ours was the first hospital he visited. He's come to the emergency. He is now E3, V2, and M5, and he's very agitated. He's not obeying commands. The planters are extensive. The serological workup is Hep A positive. I'm just going to do the very salient points. Next slide, please. And these are his labs at presentation. Now, the INR is 3.9. Bilirubin is about 11. AST, ALT in several thousands. Ammonia is 794. And lactate is 5.3. So now next slide, please. Now next, please. Now the first question that I'd want to ask Dr. Sumit, Dr. Arvind, is do we electively intubate this patient? And next as well. And what are the precautions that we take while we're intubating this patient? Any specific anesthesia-related precautions that we take? Next.
Yeah. No doubt this patient needs intubation. He has a low GCS and is agitated. The patient needs intubation. There is no doubt about it.
Yes, it's also because this time that he comes to us, intubation is also, I think, a period where he also has the highest risk of raising the intracranial hypertension and everything. Are there any specific measures that you would take or be careful for, sir, to ensure that the intubation itself is safe?
For intubation, I would maintain the deep depth of the anesthesia. It should be deep enough to prevent any pressure response to laryngoscopy and intubation. And I would like to maintain the head up position while intubating, and try to maintain head in the neutral position.
Yeah, okay, that's a very salient point, sir.
And also, I'd like to add that intratracheal spray of lignocaine would also help to reduce the response.
Yeah, that's a very important point, sir. That's a very important point. Next, please. Next. Now, this is an important, we touched upon this briefly earlier, sir. Now, if the patient is intubated and then shifted directly to the ICU, a transplant ICU, I'd like opinions from Dr. Charles, Dr. Rakhi, and maybe Dr. Dinesh as well. Would you consider shifting the patient back down for a CT or an imaging? That's the first scenario. The second scenario, of course, ideally, if he's had an imaging because of altered sensorium and a different differential, that's a much better for the treating team. But if he's already shifted up to the ICU, in any scenarios, would you then shift him back for a CT or a neural imaging?
Dr. Shashwat, Charles here. Hi. At least in our center, we take them for a CT only prior to shifting for a transplant. And second is, if the patient's got any neurological finding that says that he has got interstitial bleed, then where you want to withdraw treatment, then we might take a CT. Otherwise, routine CTs are not done once the patient is shifted.
The question is really, Dr. Charles, is that, here's a very short history. You don't know what's happening, whether a person is, so would a CT or MR be done? Or are you sure that this is all just acute liver failure?
We wouldn't do a CT now. We will work up the down. If the patient is being planned to be shifted to a theater, then we would take a CT. Otherwise, no. And CRRT is any patient with a intubated patient, ammonia more than 150, lactate is not responding to your hydration, then definitely we will start him on CRRT.
Can I just say, I mean, yeah, I agree with what Charles is saying. So if the patient ammonia 794 is extremely high, very high risk of cerebral edema and herniation, we should minimize any movement of this patient. If the patient is intubated in ER and shifted to ICU, we should keep them in the ICU unless the neurological status changes where it may warrant a CT. At this point of time, in this particular scenario, what you just mentioned, Most of the time we do CT on the way to the ICU, but if it's not been done, we just hold on to that and manage the patient, bring down the ammonia first, because that's a very important prognostic marker in patients with acute liver failure. And once you hook them onto CRRT, again, you're almost 48 hours, 72 hours, you cannot do much about the CT brain. So it will be wise to do a CT brain before you shift them to the intensive care unit. If it's not done, it's better to manage as acute liver failure, do all the measures as what you do. And unless there is some different in the neurology, unequal pupils or dilated pupils, or change in your blood pressure and the pulse rate, Cushing's reflex. Yeah.
So the question here is that when the patient first presents to AR, which is very unusual for us because most of the transfers happen directly. Here's somebody who came, said, all of a sudden with a short history to our emergency room, and then they contacted us. So we don't know the diagnosis. We have no values at that moment. But someone with sort of, very short history of neurological impairment, are you convinced that it's ALF or is it something else? So that's really the question.
If somebody
you don't have going to have the ammonia value straight away with you.
Yeah, if you don't have ammonia value, then definitely we need to rule out other things. If the particularly guy is irritable, and if you're not convinced about ALF, then definitely we should do a CT brain to rule out intracerebral events. That's 100% correct.
What happens is that
we do in our center is basically, if the patient lands in emergency like this, while shifting to the ICU on the way, get the quick CT, a pan CT, and then quickly shift to the ICU.
Yeah.
Fair enough.
Next, please.
Yeah.
So this was how we managed this patient was in the ICU. We monitored for signs for intracerebral hypertension. Next, we've already discussed this. I'm going to move to the questions. This is also the first question. The first part we've covered at length, the ammonia lowering measures. Now because of this patient, we were managing him conservatively and trying to see if we could do some medical management and avoid transplant, even though the donors were all counseled and the family readied. I'd like to ask Dr. Abhideep and Professor Gupta is, what are the signs of worsening? We've discussed intracranial hypertension. Are there any red flags which you immediately would pick up during the ICU and be like, okay, now we should go ahead and this conservative measures are now failing?
I'm not going to answer because I manage this patient. It's a true case. So let Dr. Abhideep answer it.
So, I mean, worsening in terms of despite all these supportive measures, if the condition remains same or worsen, definitely will be taking this patient for transplant. But then, so deteriorating INR, obviously, I mean, as Raki just pointed out, if it goes beyond 6.5 and becomes a standalone criteria, I mean, obviously, we're not going to wait further on that.
We also look for worsening lactate, patient going on supports.
Yeah. So if there is now development of slight organ failure, there's an increase in NORAD and the lactate's increasing, and there is renal dysfunction. Are you more inclined towards to wait or to optimize, or what point of time will you then just be like this is not working?
Make a point.
Yeah. Shashwat, can I just add?
Please, Dr. Dinesh, go on.
I'm saying this is a 20-year-old guy, hyperacute liver failure, hepatitis A. There is a high chance this guy will have
reversibility.
Okay, therefore, we should be very aggressive in managing this patient.
So,
bring him out without liver transplantation.
So this is a classical case where the patient has presented with very severe prognostic parameters suggesting the need for early transplant, and how we can turn around this patient considering the few points like hepatitis A, hyperacute, severe cerebral edema, hyperammonemia, lactates are high, but still that is how these patients with a combination of PLEX and CRRT, by 24 hours, we can make that assessment whether he's moving towards transplant or away from transplant. And there is where the dynamic assessment becomes very important when the patients are subjected to extracorporeal therapies. So how effectively they are reducing their ammonia? Are we needing to increase the dose of CRRT? Ammonia clearance is not effective. PLEX, after plasma exchange, what is the rebound increase in INR? All that will tell us whether we need to go and rush in for a transplant or we can wait on this patient for a spontaneous recovery. So these are the patients who can actually go in either direction.
Yeah, Shashwat, carry on.
Right.
Yeah, so ma'am, this is exactly, we did most of those measures except the extracorporeal therapies. So the patient was intubated. He's day 3 now. He's hemodynamically stable. His inotropes are coming down. He's got some slight fever, 100 or so. Good urine output. Signs of pupils are nice and reactive. Lactate is improved. INR is improved. The LFTs are better. The ammonia is still high, possibly. These are the labs on day 3. Ammonia is still about 600 or so. Lactates come down, INR of 2.3. Billy is still high. Next, please. Now, 2 or 3 things. The patient's improving. Now, I've skipped a few slides so that for lack of time. The patient improved, got better. So we as a center are in favor of an early tracheostomy. If we feel that the patient would have a protracted time, we are in favor of.
A key question here is, when do you stop sedation to assess that person recovered from encephalopathy? And how do you do it? This is because if you keep them long on the ventilator, they'll get up with pneumonia or something. And this we've seen repeatedly that patients have recovered from ALF but died from septicemia. So a very important question here that but if you want to stop it early, then you may worsen the cerebral edema.
Yeah, of course.
So what are the parameters that help you guide in this?
Can I take this question?
Yeah,
How
please.
we do it in our
That's
ICU? Yeah, so the first criteria that we look forward is obviously the patient should have a normal lactates, which is the protocol, PF ratios, no vasopressors. Everything else is better. With respect to acute liver failure, we look at the trends of INR. We obviously look at the ammonia measurements. If the ammonia is very high, we do not break the sedation. If everything else, ammonia, INR, everything is showing recovery, we do go with the non-invasive surrogates. If those are also good, our optic nerve sheath diameter is good, pupillary reactions are good. So normally we put these patients on paralytic agents along with fentanyl and propofol. So very gradually we start withdrawing the paralytic agent. And if the patient is well, he starts waking up immediately. If the patient is sick, we start seeing some deterioration. They start hyperventilating. So we are very careful while switching off sedation. So one is the checklist and then is the monitoring once we are stopping the sedation.
Dr.
And
Rathi,
it's
what
a
is the
very good
cutoff
sign.
of
The brain recovers.
How
These patients, this is a very good sign of recovery. Yeah.
cerebral edema?
Yes.
When do you know that you will not, when they're struggling from sedation, that you will not worsen their cerebral edema? That's a key question. I've never not found an answer to that.
So these are the
What
like
point
600
Obviously,
ammonia. I would target the ammonia down. I would see that there is no rebound increase in INR. The patient is having clear-cut recovery of acute liver failure, and the patient has no other parameters to suggest with respect to the lung circulation and other organs or metabolic components that there is anything to suggest that he should not be given a sedation interruption. This is where we make sure, and then we very gradually switch off the sedation, and most of these patients wake up.
I think
using this
is there any
protocol.
cutoff of ammonia you follow?
Yes, sir. So for us, it is not cut off, but obviously for us, INR we see as a more reliable parameter. Ammonia should be down below because our levels, I don't know, as compared to the Western literature, we see very high values. So we don't go by 150 cutoff. If the patient is showing recovery and the ammonia levels are below 200, we do consider giving a sedation interruption if our ONSD and other parameters are also good.
See, Rakhi, you said absolutely correct points and they're very well taken. I've realized that in these situations, we cannot have cutoffs, very difficult. But
Yeah,
the
very difficult.
bottom line is, in ALF patient, somebody in grade 4 coma, you reduce the sedation a little bit and patient starts opening eyes.
That is
bit of stars. If the INR
yes,
5 and spontaneity is 4 and 3, the next 12 hours, believe me, that bit of improvement is very, very, very positive sign in these patients. And invariably, then they go through the course of recovery. So, it's like that, once patient starts, showing, opening eyes and all, it's a huge, huge thing. So therefore, it's
so for us, INR is a more reliable parameter to suggest liver recovery, and ammonia should be below. It should not be too high for us, and obviously other parameters. Yes. Agreed completely.
Great. Anyway, you're right. Iron falling is a very important point. Yeah.
Dinesh, anything you want to add to that?
No, I agree with what Rocky said, and it's more of how the rate of ammonia drop. And here we have not seen much drop. It is still quite high, so we should not stop the sedation.
Yeah,
It should
not
come
at all
down to
at
a
this.
very safe limit, 150 to 200, I would say, and then we can stop. And also the other parameters, whether they're waking up, the pupils are reacting, and how the hemodynamic status, all those matters when you deal with such patients.
So I think it was a great discussion. So final concluding comment by Dr. Saigal, and then maybe Dr. Gupta can do a concluding comment. Sorry, Shashwat, I'm just interrupting in view of
No worries,
the
sir.
time.
Well, I can appreciate Abhishek's crunch for time, and I'm sure if there's a permission, we would have gone on for next 1 hour. But I think we have this time constraint, and I will a very brief, thing gist of what we discussed. This has been an extremely educative session for all of us. I personally have learned a lot, and we started with an excellent overview from Dr. Gupta, and he highlighted the facts that we cannot have a straightforward answer to everything in ALF. Now, Shekhar spoke on prognostic factors. We agree that King's College is not the ideal for Indian situation, and perhaps it's time that we, as society, should enter into some sort of multi-center involvement and start looking at validation of Indian parameters for prognostication. I think that's absolutely the need of the day. The last one was Alfred, and after that, nothing has happened in Indian context. So let's not, stick on to King's College. I think perhaps we should starting our own devising criteria and validation. Dr. Arvind had an excellent talk on ICU care, and we learned from Vipul that a pediatric ALF is not like a miniature adult, but I think that what he wanted to say that in pediatric ALF we could really be waiting for more before we jump onto transplant, because there's a thought that they have a better scope of recovery than the adults. Well, that's possible. Uh, Rajesh, Dr. Gupta presented the talk, an excellent talk, and I think when not to transplant is very difficult. Let me tell you, whatever we say, we as a team, as the surgeon especially, we are never willing to give up, and that's the spirit of the teams, because invariably giving up is very difficult. And yes, I agree, LDLT is more challenging, but if an ALF is there and it needs a transplant, then we try to go like beautifully presented by Srijit in the case that even if we're mid-dilated, people not reacting, we went ahead and it did a successful transplant. Sumit beautifully presented his anesthetic considerations in ALF. What he highlighted was BIS monitoring and for depth of anesthesia is very important. And of course, we should, be using a very intense neuro monitoring for these patients. Whatever you have, I think all units in India now must have ONSD. I'm aware pupillometry is not present everywhere. We are using pupillometry regularly and BIS monitoring. Whether we should start doing reverse jugular saturation, which I think we should be doing. I used to do it regularly in Kings, but I think we should start doing it also because we are not doing bolt monitoring, so it may add on to our armamentarium. Then Mukesh, surgically, one thing he mentioned that we transplant ALF out of hours. So therefore, the team must have the highest expertise. This is very important thing that whoever is doing a new team, for example, if you're doing an ALF out of hours, the expertise should be right from top to bottom. Everyone should be absolutely, brilliant in their, expertise, so that the outcome can be the best. So I think we have two nice cases after that, and I think I'll invite Dr. Gupta to make any comments before we wind up this session. Professor Gupta, please.
Thanks, Abhideep and LTSI for allowing us to do this. It's a very popular topic with us because, as you probably realize, we hold some contrary views to the general sort of accepted wisdom, which is to do early plasmapheresis and early CRRT. And I'm still not sure that is because one of the problems we faced and has been highlighted with plasmapheresis, we used to do it a lot, is that you lose the single prognostic value of INR to determine whether the person is improving or not improving. With CRRT, a lot of people say ammonia comes down. We have with normal renal function, we've not seen that happening. Perhaps something that we don't do correctly. Maybe we'll come and visit the Dinesh and ILBS and see how they bring down the ammonia with CRRT. But this is a practical problem that we face, and we've actually found that many of these patients end up with sort of infection. And I remember one patient, I remember with Vipul will also remember, whose INR was persistently 10, more than 10, till we stopped the CRRT, and then we checked the INR 6 hours later, and that was much lower. Vipul will remember that case, and that child went on to have complete recovery. Thank you very much for giving us this opportunity for doing this masterclass.
Thank you. So on behalf of LTSI, I would like to take a moment to express my gratitude to Dr. Gupta, Dr. Saigal, and CLBS team for sharing their expertise, their clinical experience, and actually thought-provoking insights. I would also want to thank Rakhi, Dinesh, Charles for giving inputs, and all the people who were asking questions to make this session really interactive. We will continue with this program of LTSI Masterclass first Wednesday of every month, 7 to 9. We'll keep on posting the notices on the LTSI group. People who are not member of LTSI can become a member and get benefit of these master classes. We are going to put the video of these master classes on LTSI website and LTSI YouTube channel for you to see this again, or if anyone has missed, can actually see this video, because these are really real life challenges that we are trying to discuss in these master classes. Again, thanks a lot, everyone, and good night, and I'll see you again on 2nd of April, 7 p.m. for the next masterclass.